Hello and welcome to today's SCR webinar brought to you by the Realtors Education Foundation. Today's webinar discusses recognizing depression and suicide prevention. Real estate agents, lenders, and closing attorneys are all high-stress professions that have high rates of depression, substance abuse, and suicide. Today you'll learn what to look out for and how to reach out to others when they need help. Today we are joined by Helen Crigden, a social worker and youth advocate currently serving as South Carolina Area Director for the American Foundation for Suicide Prevention. She is a principal founder of the AFSP South Carolina chapter and served as board chair for 3 years. She also served as state coordinator of South Carolina's nationally recognized foster care independent living program until March 2011, where she supervised program implementation through DSS county and regional offices and in partnership with other state agencies and private providers. Helen provides trainings at the local, state, and national levels in both youth advocacy and in suicide prevention, as well as survivor support.
Thank you. I'd like to express my thanks to the South Carolina Realtors Association for inviting me to be here today. Concern about this important topic. I respect your work in helping families find homes and places in community. The mission of the American Foundation for Suicide Prevention is to prevent suicide through education, through research, through advocacy, and through services for survivors, those who have lost loved ones to suicide. We provide educational programs for both the public and for professionals. We are the largest nonprofit funder of research on suicide prevention in the United States. Many people who receive grants from our organization go on to receive larger grants from the National Institute on Health. We have a policy office in Washington, D.C., and that office works with us on certain legislation and on policy nationwide. We provide services for survivors, those who have lost loved ones to suicide, and we have a great deal of information on those services on our website. You'll see the posting for the website later in the presentation. I know that many of you have busy lives. You're on the run with your jobs, with your families, and I thought about this brief meditation this morning that I want to offer to you. There was a college professor who visited a Zen master, and he went to this Zen master because he wanted to increase his knowledge. The Zen master observed him for a while, and then he asked his assistant to go get a pot of tea and bring it to him with 2 cups. The Zen master placed a cup in front of his visitor, the college professor, and one in front of himself, and he began to pour the tea for the college professor. Soon the cup overflowed, and the tea was pouring over the edges. The college professor said, "Stop! The water is overflowing. Stop!" The Zen master looked at him, and he said, "So it is with you. Your cup is also overflowing. You need to take a little bit of water out of the cup so that you can take in more knowledge, that you can increase your knowledge." So I'm going to ask you today to sit back in your chair, take a deep breath, close the door if you need to, and be present to this presentation over the next hour. You're going to receive a great deal of information, and it will help you to get ready for that. Suicide is a difficult topic. It's a very sensitive topic, and a lot of people are uncomfortable talking about it. But if we don't talk about it, how are we going to prevent it? How are we going to do anything about it if we can't talk about it? It hasn't been that many years ago that people felt the same way about cancer. Cancer was a taboo topic. People were ashamed to tell other people they had cancer. Look now at all the research, all the treatments, all the ways that we can address cancer and prolong life. Suicide is now the 10th leading cause of death in the United States. So we are all involved, all of us, The name of this presentation today is Suicide Prevention, Saving Lives One Community at a Time. You don't know when you may be the last voice a person hears in a given day. This presentation may be helpful to you regarding a family member, regarding a coworker or a friend, or even yourself. Let's look at some of the facts. In 2009, almost 37,000 people died in the United States by suicide. About every 14.2 minutes, someone in this country intentionally ends his or her life. There are 1 million people who die worldwide each year, but in the United States, 37,000. The rate was falling between 92 and 2000. However, it's been fluctuating, going back up since the year 2000. In South Carolina in 2009, we lost 612 citizens. 2008, 560. So you can see the rate, the numbers are also going up in our state. Now, this doesn't speak to the number of attempts for each death, for each person who ends his life. With adults, there are 25 attempts for each death. When you're talking about young people, when you're talking about youth, there are 100 to 200 attempts for every death. Suicide is considered to be the second leading cause of death among college students. And I want to stop here to say that you may want to enlarge your screen on your computer so that you're not looking at me, that you're looking at the PowerPoint. It's going to help you to listen as I speak, but to also be looking at the slides. And because some of the print is a little bit smaller, you may want to enlarge your screen so that you're able to see it. Suicide is the second leading cause of death for people ages 25 to 34, third leading cause of death for people aged 10 to 24. I pulled the data for youth ages 10 to 19. This would be the age group in our public schools because we provide training with the Department of Education. And I discovered that suicide is the third leading cause of death for youth ages 10 to 19, not only in our state, but in our nation. Suicide is the fourth leading cause of death for adults between the ages of 18 to 65, and it's also highest in white males over age 85. Although suicide rates in the U.S. are highest in the very elderly, because there are so many other reasons for death in this age group, it is not determined to be a leading cause of death. The suicide rate in 2009 was 12 for every 100,000 people. It greatly exceeds the rate of homicide. Most people don't realize this. Everybody thinks that more people are dying because other people are killing, or because people are killing other people. But the fact is, more people die by suicide. Well, over double the number die by suicide rather than homicide. In our state, if you look at the state ranking for South Carolina, we rank number 24 in the nation among all states. We're kind of hover in the middle in our own suicide rate. Psychological autopsy studies done in various countries for almost 50 years report the same outcomes. 90% of people who die by suicide are suffering from one or more psychiatric disorders. Major depression, bipolar disorder in the depressive phase, alcohol or substance abuse, schizophrenia, and personality disorders such as borderline. Suicide is not predictable in individuals. It affects individuals of all races, creeds, incomes, and educational levels. Anyone can die by suicide with all the right factors, or we might say all the wrong factors in place. There is no typical suicide victim. Suicide communications are often not made to professionals. In one psychological autopsy study, only 18% told professionals of their intentions. In a study of suicidal deaths in hospitals, 77 denied intent on their last communication, and 28% had no suicide contracts with their caregivers. In adolescents, 50% communicated their intent to a family member. So if you have a young person in your home who communicates this message to you, listen. Don't discard it or not take it seriously. Listen to them. In the elderly, 58% communicated their intent to the primary care physician. It's interesting that a lot of people go to the doctor before they take their own lives. Not only the elderly, but other people often make a visit to their doctor before they take their life. I'd also like to interject here that among adolescents, 1 out of 10 adolescents in the United States struggles with a mental health problem. We conducted the Annenberg Adolescent Mental Health Initiative, and you'll find that report on the AFSP website. And that report told us that 20 to 30% of adolescents report symptoms of depression. The mean onset of depression today is age 15. Research shows that during our lifetime, 20% of us will have a suicide within our immediate family. Now, this can mean someone who died in your family before you were born, or it could be someone who dies in your lifetime. I often talk to people, or people who've become involved in our organization and volunteers, and at first when they come in, they want to help because they care about the cause. And then over months of their service, they will find out that actually someone in their own family died by suicide, and it becomes even more important to them. 60% of us will personally know someone who dies by suicide. And the number of deaths, if you look at deaths in the United States in 2009 by cause, and I hope everyone can see this graph because I think it will be very informative to you. Look at asthma, that little tiny bar at the bottom, 3,388, HIV/AIDS, 9,406, Parkinson's disease, 20,565, suicide, 36,909, breast cancer, 40,610. And we're all aware of the tremendous efforts regarding breast cancer, the large number of funds that we raise for breast cancer, and that is good. We've got to put more effort into suicide prevention as our numbers are growing here as well. And then if you look at diabetes, you see the numbers there, 68,705. You can pull this kind of information up on the website of the National Institute on Health or do a search if you're interested in this kind of information. Okay, research dollars spent by the National Institute on Health. And I want you to understand this represents millions. When you're looking at these dollar marks, this isn't 221,000, this is 221 million. Now look at the money that's spent on research for asthma, for HIV/AIDS, for Parkinson's, for suicide, for breast cancer, for diabetes. For suicide, you'll see 49 million is devoted to suicide research, 712 million for breast cancer, over a billion for diabetes. But you can go back and look at these slides at your leisure. This is of interest to you. Facing the facts. Prevention may be a matter of a caring person with the right knowledge being available in the right place at the right time. And that person might be you. Let's look at some of the myths surrounding suicide. Myth versus facts about suicide. 1. People who talk about suicide don't complete suicide. Fact. What is the truth? Many people who die by suicide have given definite warnings to family and friends of their intentions. Always take any comment about suicide seriously. Myth. Suicide happens without warning. We just did that one, didn't we?
It's kind of similar.
Yeah, no, it's very similar, so we'll repeat it. It's worth giving attention to. Most suicidal people give clues and signs regarding their suicidal intentions. Suicidal people are fully intent on dying. No. Most suicidal people are undecided about living or dying, which is called suicidal ambivalence. A part of them wants to live, however, death seems like the only way out of their pain and suffering. They may allow themselves to gamble with death, leaving it up to others to save them. I find it interesting that in a study of the Golden Gate Bridge, where so many people have ended their lives in San Francisco, a study of people who have jumped off that bridge discovered that most of those people were not facing the ocean. They were not facing away from us. They were facing land. And this represents that ambivalence, the tie to us even at the point of death. Most people are overwhelmed at a point in time beyond their capacity to cope, and they feel that this is the only way out of their pain and suffering. Men are more likely to be suicidal. Men are 4 times more likely to kill themselves than women. However, women attempt suicide 3 times more often than men. And by the way, this is true across the age span. More men die by suicide than women. And another reason for this is that men use more lethal means to end their lives, often guns. Asking a depressed person about suicide will push him or her to complete suicide. No, the truth is, the studies have shown that patients with depression have these ideas, and talking about them does not increase the risk of them taking their own life. In fact, a lot of people are glad that somebody's asking, that somebody has opened the door to talk about this. There is some measure of relief that someone is talking to them about it. Improvement following a suicide attempt or crisis means that the risk is over. No, most suicides occur within weeks or days of improvement when the individual has the energy and motivation to actually follow through with his or her suicidal thoughts. The highest rates are immediately after a hospitalization for a suicide attempt. Once a person attempts suicide, the pain and shame they experience afterward will keep them from trying again. No, the most common psychiatric illness that ends in suicide is major depression, and this can be a recurring illness. Every time a patient gets depressed, the risk of suicide returns. This does get better with time, and I do want you to know that most people who are diagnosed with a clinical depression will not attempt suicide. But for those who do, it's important that you know that a risk factor is that they have had a diagnosis and they are experiencing a major depression or other mental illness. By the way, in the people who talk about suicide to others, 50% will communicate this to a spouse. Often it's unbelievable to the spouse that this can happen. And 40% reveal this to a coworker. So if you're listening to this today, please understand that you may have a coworker who communicates to you that they are at risk of suicide. And as we go on, you'll learn more about what to do if this happens. I'm going to move through some of these notes. And I want to mention that after a psychiatric hospitalization for depression, the days immediately following the discharge are a high-risk period for suicide, and this diminishes over the year. So if you have a loved one who has experienced this, it's important you are aware of that if you didn't know that before. Myth: suicide occurs in great numbers around holidays in November and December. Nope. Actually, the highest rates of suicide are in May or June, while the lowest rates are in December. And I've heard it said that some studies seem to indicate that springtime is a time that represents new beginnings for the earth, for life, and often for experiences that other people are having. And when you're undergoing a depression or other form of mental illness, you may not feel that this is happening for you. So actually, springtime can be a heightened risk time for a person who may be contemplating suicide. Okay, now we're going to look at risk factors for suicide. And because people who are experiencing depressive disorders present with a wide range of symptoms and severities in a constantly changing environment. And by that I mean their stresses and supports fluctuate. Also, their suicide risk can also fluctuate over the course of an illness from a chronic high state of severity requiring long-term preventive measures to what is called an acute state of suicide risk that requires an immediate intervention. I compare this to a heart attack. If you think of someone who's at risk of a heart attack, think of that in the same way you would an acute high-risk state for a person who's in a suicidal crisis. You'll understand this more as we go on. And this is true, for all of us, no matter whether we're depressed or not. Our environment, the stresses in our lives, what's going on with us, the support systems we have at any given point in time fluctuate. And so this is true for a person who's experiencing depression as well. Some of the risk factors, psychiatric disorders. We've already mentioned that 90% of people who die by suicide have a psychiatric disorder at the time of death, whether or not it has been diagnosed, whether or not they are in treatment. A history of past suicide attempts, certain symptom risk factors, socio-demographic risk factors, and environmental risk factors. Most common psychiatric risk factors resulting in suicide are depression, major depression, bipolar depression. It's good for you to hear this again. Alcohol abuse and dependence, drug abuse and dependence, and schizophrenia. And sometimes people who are abusing alcohol and other drugs are attempting to self-medicate. They're trying to feel better or to feel normal. But this also complicates and compromises brain chemistry in these efforts. Other psychiatric risk factors with the potential to result in suicide are post-traumatic stress disorder, PTSD, and you often hear this or you read about this in the news with soldiers returning from the Middle East. You also hear about traumatic brain injury, eating disorders, borderline personality disorder, and antisocial personality disorder. All studies agree that one of the warning signs for death by suicide is a recent or past suicide, and the more serious the attempt, the more serious the risk. Symptom risk factors during a depressive episode that you may be able to observe are desperation, that you note someone that you are concerned about seems more desperate. They are feeling more hopeless. They have a greater sense of anxiety. They may be having panic attacks. They seem more aggressive or more impulsive. They've made preparations for a serious suicide attempt. They've rehearsed a plan. They know how they may do this. They've recently been hospitalized for depression, and they may have experienced psychotic symptoms. And a lot of people don't realize that during a major depression, you can experience some psychotic symptoms, and that means like having some hallucinations or hearing voices. Of course, this happens in schizophrenia, but there are other mental illnesses that you can also experience short-lived psychotic symptoms. 19% of people who die by suicide, in fact, do experience psychotic symptoms and may have some unusual behavior that you haven't witnessed before. Other risk factors are major physical illness, especially recent, being in chronic physical pain, having a history of childhood trauma or abuse, or being bullied. I had a mother in my office this week whose daughter in the 7th grade has been bullied, has been experiencing bullying, and she is also experiencing some depression. And the mother found a rope in her room. She wouldn't mind me sharing this with you. This isn't the only story of this that I could share with you, but the rope was ready, and the mother found it in the room. She's taken the doors off of the rooms. The child is in therapy. The doors have been removed from the bathroom, from the child's bedroom, and she's being closely monitored. A family history of death by suicide increases the risk factor because it opens the door. More people in the family may consider suicide after a family member has been lost by suicide. Drinking and drug use, I've also mentioned that. Being a smoker seems to be another risk factor. All of these are acute and long-term risk factors for suicide, but usually in the presence of major depression or other psychiatric disorders. Socio-demographic risk factors, and these are just examples. This is not an end-all list. These are just examples. Being male, being over age 65, being white, separated, widowed, or divorced, living alone, being unemployed or retired, and you may think of people you've worked with who've gone through employment issues recently. In our current economy, it's affected many people. Occupations, certain occupations carry risk factors. Health-related occupations, dentists, doctors, nurses, social workers, and find it's especially high in women physicians. Lawyers are also at risk. There are other professions that carry certain risk factors. By the way, these factors are all associated statistically with an outcome, with a risk factor of an outcome of suicide. Of course, alone, these risk factors predict nothing. Like those mentioned on the previous slide, these add to concern when they are present in a depressed person. We really need to emphasize environmental risk factors, and that means easy access to a lethal means, having a firearm, having access, a surplus of pills, a place to jump from, the bridges, that a lot of people are looking at barriers for bridges now, but having easy access to a way to end your life. And I strongly recommend that if you have a person who's experiencing mental illness in your home and you see these risk factors, remove that weapon from your home. Make sure everything is locked up and that person does not have access to a way to end their life in your home. Also, we look at local clusters of suicide that have a contagious influence. There are sometimes if a well-known figure, a movie star, a rock star, die by suicide, sometimes this has a contagious influence on other people. Okay, we're going to look at preventing suicide one community at a time. What can we do? What can we do in communities to prevent suicide? Prevention within our community, we need to look at education, and I commend you on what you're doing today. You invited me to be here. You're interested in this topic, but don't let it stop here. Continue to look at education. Screening, treatment, means restriction, media guidelines, and we're going to go through that. education, again, having individual and public awareness. We have helped in funding the brochure for the Suicide Prevention Coalition in South Carolina. If any of you would like some of those brochures for your offices, please let me know. They also include some tips for businesses and organizations, other things that you can do, and also ways you can be involved in your communities. Greater professional awareness and educational tools. Under individual and public awareness, understanding that the primary risk factor for suicide is a psychiatric illness. Understand that depression is treatable. Please hear me on that. Depression is treatable. Help destigmatize the illness. It is not a character flaw to experience depression or another mental disorder. You don't feel like it's a character flaw if you have diabetes. You don't think it's a character flaw if you have cancer or heart disease. Help to destigmatize the illness. The brain is a part of the body, and brain chemistry can be compromised, just like your body chemistry is compromised during diabetes. So help people, help the men, help the children, help the women, help everybody in your family understand that they are not failing because they ask for help, that they need treatment, that they need attention. So destigmatize treatment. If somebody in your family is experiencing treatment, encourage them. Encourage them. Sometimes it takes a while to find the right treatment that works for you, and you need encouragement to stay in treatment. And sometimes you need to change the professional that you're working with. And if it doesn't work, don't give up. Encourage help-seeking behaviors and continuation of treatment. Professional awareness. We need greater awareness among our healthcare professionals, among physicians, pediatricians, nurse practitioners, physician assistants. We need even greater awareness among mental health professionals, among primary and secondary school staff, principals, teachers, counselors, nurses, among college and university resource staff. You can read all the names there, all the categories, among gatekeepers, religious leaders, the police, fire department, armed services. We just provided training for the Attorney General's office for the Safe Schools trainings all around the state, and we had so many school resource officers there, other people from law enforcement, administrators, so many people came to that training. We need to expand and grow trainings among all these populations. Educational tools. These are some of the programs through AFSP, depression and suicide among college students. We have provided this training packet, The Truth About Suicide, Real Stories of Depression in College. This is a DVD that comes with a facilitator's guide. We have provided this to each public college in the state a couple years ago. It's time for us to do that again. If you're listening and you have a contact at one of the colleges and you want us to provide that to that person to make sure it's implemented on that campus, please let me know. We'll work with you in making that happen. Also, depression and suicide among physicians and medical students. We have a training, we have a video and the training guide, the PowerPoint, and we have provided this at for the USC School of Medicine, so that the USC School of Medicine has this for their residents and for their staff. We've also provided it for Medical University in Charleston. It's in that medical school. And this year we'll also be providing it for the new medical school in Greenville. And then let's talk about depression and suicide among teenagers. We have a training program called More Than Sad that comes with a facilitator's guide and resources, and we have suicide prevention education for teachers and other school personnel. And we have been conducting a training of trainers for school guidance counselors so that they are enabled, they're empowered, and they have the tools to go back and do training for other school staff. We have worked on legislation on the Jason Flatt Act that was passed in May of this year. And that legislation now requires that all certified school personnel participate in 2 hours of suicide awareness and prevention training before they are recertified. We are paying for all of these programs through our Out of the Darkness community walks. We encourage you to join us in those walks. If you would like to become a sponsor, we have a number of businesses and organizations that are sponsors. We invite you to take part and help us as we are working very hard to prevent suicide in our state and our communities. Screening for at-risk individuals. You may have heard of the Columbia Teen Screen, and there are many other screening programs. There's also the AFSP Interactive Screening Program, and it can be used with students, faculty, employees. It's the military. There are some people who are looking at it to use with soldiers who are coming back from the Middle East. For veterans, it's being explored. But currently, we are funding the interactive screening program at the University of South Carolina and at the College of Charleston. We will be adding a third college this year. But this program is a confidential program so that a student can participate in the screening, and there are steps, and they're anonymous, and we work with them to get them to the point, if they're at risk, that they come into the counseling center so they receive the attention that is needed to help save another life. We are growing this program, very excited about it, very proud to be involved. So that is good news too for today. There's a lot of good news in the work we're doing. I know this is a tough topic, but there's some good news in the process about good things that are happening because this community cares. We care. When we look at treatment, thinking about antidepressants and psychotherapy, it's important that a person is involved with adequate treatment and monitoring. Only 20% of medicated depressed patients are adequately treated with antidepressants. This is possibly due to side effects, a lack of improvement. That doesn't happen overnight. Sometimes it takes a while to find the right medication. High anxiety they may be having a lot of anxiety, and that's not being treated. A lot of people have a fear of drug dependency. Sometimes people are also using other substances at the time, and sometimes people decide they'd rather use that than the medication. Sometimes the antidepressant is not being combined with psychotherapy, and that's important. Sometimes the dosage is not high enough. And sometimes that person, the condition may be one that also requires an adjunct therapy such as lithium or another medication. And occasionally all the options haven't been explored, like electroconvulsive, you are familiar with shock therapy, ECT therapy, or some other somatic treatment. Psychotherapy research shows that when it comes to treating depression, all therapy is not created equal. Study shows that applying correct techniques reduce suicide attempts by 50% over an 18-month period. To be effective, psychotherapy must be specifically designed to treat depression. Relatively short terms, 10 to 16 weeks, needs to be structured. Therapists should be able to give step-by-step treatment instructions that any other therapist can easily follow. By the way, I'd like to mention here that South Carolina can be very proud of a new rural hospital initiative that there is telepsychiatry, and the Department of Mental Health is involved in this. USC School of Medicine under Dr. Mira Narasimhan is involved in this. They've received a huge NIH grant, and they have monitors in a lot of these rural emergency rooms so that the attendant and the patient can be served through telepsychiatry. They've already worked with over 10,000 South Carolina residents with this program, and it's being very effective. So you can go online, pull up her name, Dr. Mira Narasimhan, and read more about this exciting program. Now, under effective psychotherapy programs, Some of you may have heard of CBT, cognitive behavior therapy, and interpersonal therapy, and dialectical behavior therapy. Under CBT, it helps us look at our thinking processes. Thinking is one thing, what you're feeling and acting, your behavior is another thing. And often people who are in a suicidal crisis get into a mode of tunnel vision. It looks like it's the only way out. And thinking can jump from A to Z. If you've grown up around some stinky thinking, that can also impact your thinking processes. And you might not realize there are other options. There are also options to the way you respond to your environment. And if you can train yourself, if you can receive help in how your thinking processes operate, it can help change your response and help you, even though you may not be able to change a situation, you can change your response to the situation. I remember a professor I had many years ago who said that sometimes we hear growing up, I can't take this anymore, I just can't take this anymore. But he said that's a learned response. And we can change that thinking about what we can. Yes, quite often we can handle more than we think that we can. And there are people who can help us and help us look at our thinking processes. And this kind of therapy, along with medication when it's needed, can save a life and turn a life around. Means restriction, firearm safety, as we've already mentioned, construction of barriers at jumping sites. You can go through looking at this list. Restrictions on pesticides. You've probably noticed a lot of changing in packaging on medications when you get a medication, or the number of pills that they will give you at one time as well. Media guidelines and considerations. AFSP has media guidelines on our website. It's very important that the media knows how to report on suicide so that they don't escalate suicide and contribute to contagion. And if you would like to read up more about this on the AFSP website, you can see the link on the slide. And if you have friends who are reporters, you might want to refer them to the website for this information. Other media considerations. When you're watching television, notice how suicide is portrayed in the media. Television, movies, and advertisements. Is it glamorized? Is it made light of? How is it portrayed in the media? You might also want to know of internet danger. There are suicide chat rooms. There are instructions. There are websites that will tell you, give you instructions on how to end your life. There are even suicide pacts online. Know where your children are on the internet. Be aware, particularly if you have a depressed child, what websites they're visiting. And this is true for other loved ones that you may have. Have an increased awareness. You can help. We're going to talk about how you can help. Know the warning signs. Know what intervention means. Understand that most people who die by suicide don't really want to die. They just want their pain to end. They're overwhelmed at a point in time beyond their capacity to cope. About 80% of the time, people who kill themselves have given definite signals or talked about suicide. Warning signs. These are observable signs of a serious depression. Pay attention now. Unrelenting, low mood. Pessimism, hopelessness, desperation, anxiety, psychic pain, inner tension, withdrawal. Is someone in your life withdrawing more now? Are they having sleep problems? Have they increased their alcohol or other drug usage? Have you noticed recent impulsiveness and taking unnecessary risk? You would be surprised at how many one-car collisions are suicide. Have you seen this person taking unnecessary risk? Are they threatening suicide or expressing a strong wish to die? Are they making a plan? Have you noticed that they're giving away prized possessions? Have they recently purchased a firearm? Have they obtained another way to express themselves? Are they showing unexpected rage or anger? And you often see this with men too, so pay attention to that. Unexpected rage or anger. And these are, you're seeing a pattern of change in that person. These are the proposed DSM-5 suicide assessment dimension risk factor groups. I hope you've got your screen enlarged right now as you look at this. You go from the lowest level of concern to the highest level of concern. 0 is lowest, and then category 4, 5 to 7 is the highest concern. Look over that list and think about the person you may be concerned about. How many of these risk factors do you see? And then look at the scale on the left, and that will give you some information you may need. And you can come back to the slide. This webinar will be posted, and you can come back to it later if you would like to. You can help in intervention. There are 3 basic steps. 1, show you care. 2, ask about suicide. 3, get help. The military, the Army, has an ACE card, ACE, and they have a program, shoulder to shoulder. They're looking out for your buddy. A is ask, C is care, and E is escort. Stay with them till they get help. I love that program. You can help, show you care. Take all talk of suicide seriously. If you are concerned that someone may take their life, trust your judgment. Trust your intuition. Trust your judgment. Listen carefully to them. Listen to what they're saying. Reflect on what you hear. Reflect yourself on what you hear, and you can reflect back to them what you're hearing. Make sure you're understanding. Use language that is appropriate for the person involved. Don't worry about saying the perfect thing or the right thing. That they feel that you are genuinely interested is what is most important. They will know if you're interested, if you're blowing them off. So don't be as worried about perfect language as you are about conveying that you care about them. Be genuine. Let the person know you care. Talk about your feelings and ask about his or hers. I'm concerned about you. How do you feel? Tell me about your pain. You mean a lot to me, and I want to help. I care about you, about how you're holding up. I'm on your side. We'll get through this. Do you hear me? Intervention 2. Ask about suicide. Be direct but non-confrontational. Talking with people about suicide won't put the idea in their heads. Chances are, if you've observed these warning signs, they're already thinking about it. Be direct in a caring, non-confrontational way. You're trying to get the conversation started. Don't preach to them. Don't make them feel guilty. Don't put more of a load on their shoulders. And understand that you're not going to put the idea in their heads. You do not need to solve all of their problems. You may be afraid of this. You don't need to solve all their personal problems. Just engage them. Questions to ask: are you thinking about suicide? What thoughts or plans do you have? Are you thinking about harming yourself, ending your life? How long have you been thinking about suicide? Have you thought about how you're going to do it? Do you have a gun? Do you really want to die? Or do you just want the pain to go away? Ask about treatment. Do you have a therapist or a doctor? Are you seeing him or her? Are you taking your medications? And then intervention 3. Get help, but do not leave the person alone. Know of referral resources, reassure the person, encourage the person to participate in the helping process, and outline a safety plan. It would be helpful if you know the referral resources in your area and that you know hotlines. Your office could create a referral sheet in case you need it. Do you know where your emergency room is, your walk-in clinic? Do you know about the resources in your area? And for your family, do you know of a therapist you would call on if you needed someone? Hotlines. I want you to memorize this number. I want you to write it down. I want you to take it with you. I want you to put it in your wallet. It is 1-800-273-TALK. This is a 24-hour crisis line. You can call it at any time and someone will be there. It doesn't matter if you are a civilian or if you're military. You can call this line. The website is www.suicidepreventionlifeline.org. Don't hesitate to share this line. And in an acute crisis, you always know you can call 911. That's what they're there for. If somebody was having a heart attack, you would call in a skinny minute, right? So if you're with someone who's in an acute crisis and you need help, don't hesitate to call 911. Reassure the person that help is available and that you will help them get help. I know we can figure this out. I know we can figure out something that will help you feel better. I know where we can get help. I can go with you where we can get help. Let's talk to someone who can help. Let's call the crisis line together right now. Encourage the suicidal person to identify other people in their life who can also help. Present parents, family members, maybe a favorite teacher, a school counselor, a school nurse, a religious leader, a family doctor, a close friend, but help them think of other people who can help. Outline a safety plan, make arrangements for the helper to come to you. Call them, get them to come to you, or take the person directly to the source of help. Again, do not leave them alone. Once therapy or hospitalization is initiated, be sure that the suicidal person is following through with appointments and medications. Very important. Now, I want to, as I'm closing this, I want to let you know that we have an excellent website. Don't sign off yet. I want you to know about this website. If you want to go to this website later and look at it, there's a lot of data. There's information on our educational programs. You can look at the warning signs again. Our research, a lot of the research and descriptions of some of the research is online. A lot of the services that are available to survivors, people who've lost loved ones to suicide. We have a number of programs for survivors. We encourage them, we encourage you to participate in our walks. We have just launched a survivor outreach program so that survivors, old survivors can call in new survivors and help them know that they can get through this tragic loss. And we also have International Survivors Day that we come together in groups around the state for a program. And I have a message to survivors today. Those of you who have lost loved ones to suicide, and I'm sure there are people listening today, I want you to hear this. You did the best you could with the knowledge you had, with the information you had at that point in time. There is so much regret when we lose someone to suicide from everyone who knew that person. We all wish we could have saved that life. And often we beat ourselves up with what we learned later compared to what we knew at that point in time. It is often just so hard to absorb that this could really happen to someone. And then when it does, you're left to deal with the pain and the shock and the loss. Also remember that person's life, not just the point in time of the loss of death, but all that person contributed to your life and to those who knew them during the entire life. So I urge you to visit the website and download the survivor booklet so that you learn more about dealing with this loss and that you're taking care of yourselves in your own grief journey. Suicide is preventable. It is often the right person being in the right place at the right time. For those of you who are listening, I urge you to take care of yourselves. You're in a very demanding profession. Be aware of what you're doing to take care of yourself. Do you have an exercise program? What do you do for your stress? What are your comforts? What creature comforts do you allow for yourself? And knowing that it's all right for you to ask for help when you need it too, and that you encourage your coworkers to do the same. Do you remember the Zen story from the very beginning of this presentation? Asking for help is another way of emptying that full cup, getting some of that water out of the cup that could represent some of the stress in your life. Asking for help, getting some of the water out of the cup. If you can understand this, if you can see this, it may be the beginning of a process that will make a new beginning in your own life. Thank you so much for inviting me to be here today. Whoops, we lost my contact information.
Oh.
Can we go back
Yep.
to the last slide? Thank you. This is my contact information. I clicked too soon and it took us back to the beginning. You see my phone number, 803-552-9318. My email address is hpridgen@afsp.org. If we can be of help to you in the future, if you're a part of an organization that would like a presentation, perhaps on the youth program prevention, let me know. And do keep learning. I think we may be having some questions that will come in, and I will stay a few minutes to answer those questions. Is there anything else from the Realtors Association? Are we finished?
Yep.
Okay.
So,
Thank you and good wishes.
well, we got a question, real quick. Does a prescription Adderall increase suicidal tendencies, and when is the next local walk in Columbia?
Oh, we were going to, are we still live?
Yeah, they're just asking.
Okay,
questions,
good. If we're still live, I want to give you the website for the Out of the Darkness community walks, www.outofthedarkness.org. We are having a walk. Please go online and register today. It will be held on October 14th. That is a Sunday afternoon, and registration is at 1. The walk begins at 2, but you can go ahead and register online as soon as possible. We have 6 walks registered in South Carolina, so just about every area of the state is covered. We're getting ready to register a 7th walk. We invite you to join us. This walk is for advocates, those who support this cause. It's for survivors. It's for people who have been at risk themselves. It's for anybody who cares about this topic. So I encourage you to join us. Now, there was a question about Adderall.
Yeah, does a prescription Adderall increase suicidal tendencies?
Suicide is very complicated, and it would be important to know a lot more about the situation, and I would be reluctant to comment on that, but I would like for you to call me or email me after the program, and I can put you in contact with someone who might be able to address that question a little better. It's more complicated than a simple answer about Adderall. Are there any other questions?
I don't think so.
Okay, well, you have my contact information. Good wishes. Thank you.